everyone, we did our project on apraxia, and apraxia can broadly be defined as a neurological disorder affecting the timing and sequencing of voluntary movement. Apraxia can be divided into two types, ideational and ideomotor. In ideational apraxia, an individual is unable to conceptualize an object or a gesture. So they lose their ability to plan and execute complex motor sequences involved in the use of tools or everyday objects. This is uncommon, and an example might be someone sealing an envelope before placing a letter inside. Ideomotor apraxia causes a disturbance in the performance of movements needed to use an object, make a gesture, or sequence complex motor activity. So subcategories of ideomotor apraxia include limb apraxia, so difficulty following a physical direction, such as jumping on one foot on command. Nonverbal oral apraxia, so someone might have difficulty smiling for a picture. And apraxia of speech, so someone might have difficulty reciting their wedding vows after the priest. So as speech-language pathologists, we are most interested in apraxia of speech. So apraxia of speech is an acquired disorder that affects the planning of speech. For speech to occur, messages are sent from the brain to the mouth, telling the muscles when to move to produce different sounds. Individuals with apraxia of speech have programming deficits that prevent the messages from being transmitted correctly. Some physiological causes of programming deficits can be explained by deficits in the motor speech programmer. The motor speech programmer is a neural network in the left hemisphere of the brain near the parasylvian area that sequences motor movements needed to speak. Within the motor speech programmer, there is a deficit in sensory feedback loops, meaning the somatosensory cortex fails to correctly integrate sensory information, whether it be auditory information or tactile cues needed to produce speech. There's a deficit that makes the planning of speech difficult. Damage to the motor speech programmer is typically caused from a stroke, a degenerative disease, trauma, or a tumor. Stroke is the most common. Pure apraxia of speech, however, is rare. This means that other disorders such as aphasia, dysarthria, and other types of apraxia tend to co-occur with apraxia of speech. It's important to grasp that apraxia of speech is not a language disorder, nor due to muscle weakness, abnormal muscle tone, reduced range of motion, or decreased muscle steadiness. Individuals with ALS know what they want to say and can move their tongue and lips. The breakdown is not in how the person thinks, but in how the brain tells the person to move. Apraxia of speech is primarily a disorder of articulation and prosody. When diagnosing apraxia of speech, it is important to look out for slow, labored, and halting speech. Individuals also portray a lot of consonant and vowel distortions, and some say that these distortions are inconsistent. However, research suggests that errors are fairly consistent in the type and location that they occur. So sometimes when people have apraxia of speech, they demonstrate groping when they're searching for what sounds to say. And they may have difficulty with respiration when it comes to taking a deep breath on command. But resonation and phonation are seldom issues with apraxia of speech.
There are many evaluation tasks that you can do with your client to determine if they have apraxia of speech. One evaluation task is sequential motion rate tasks, or SMRs. So a person who has apraxia of speech is really going to have difficulty with SMRs opposed to AMRs. A person who has difficulty with AMRs or alternating motion rate tasks usually has ataxic dysarthria and not apraxia of speech. Another evaluation task is having your client participate in conversational speech or reading something out loud. These tasks help you look at their prosody and see if their prosody is affected. Another evaluation task is having your client repeat words of increasing length or having them read or repeat low-frequency multisyllabic words in either isolation or in sentences. when you are diagnosing apraxia of speech, you really want to take a list of speech deficits that your client has, and there needs to be a significant number of speech errors that match apraxia of speech to really give a good diagnosis. So there are 4 categories that determine a correct diagnosis. One is primary clinical characteristics, for example, groping. The second is non-discriminative clinical characteristics, so those include your SMRs. The third and fourth are behaviors usually found in disorders other than apraxia of speech, or behaviors that rule out the presence of apraxia of speech. So these are characteristics like speaking at a fast rate or replacing one word for another. Those 2 things usually can rule out apraxia of speech and indicate your client has something else and diagnosed with something else. There are other diagnostic considerations to look at when you're evaluating. You want to rule out conditions that cause movement difficulties that are similar to those seen in apraxia of speech. So you want to rule out muscle weakness, sensory loss, comprehension deficits, and incoordination.
Hi, I'm Erin, and I will be discussing the second portion of evaluation of speech for someone with apraxia of speech. This section mainly focuses on differential diagnosis and how you can tell the difference between apraxia versus a different kind of speech impairment. The first one being differentiating between apraxia and aphasia. So these can be fairly similar and they can occur at the same time. So there's 3 different situations that can be difficult to determine with apraxia of speech. And the first one is having apraxia by itself, having aphasia by itself, or having both co-occur at the exact same time. With apraxia of speech from literal paraphasic errors and aphasia, that can be the same thing as both of them occurring at the same time. And the third one being apraxia of speech from non-fluent language errors of Broca's aphasia. So those are the 3 difficult situations that can present themselves when you're evaluating someone with apraxia of speech. Another differential diagnosis that you can have is knowing the difference between apraxia versus dysarthria. So one of the things that's different between apraxia and dysarthria is that speech errors in apraxia tend to increase as word complexity increases and sentence complexity increases. But with dysarthria, they tend to be fairly consistent and they stay the same throughout speech. Another type of difference between apraxia versus dysarthria is with dysarthria, usually at least one muscle group or one muscle quality can be affected or impaired. But then with apraxia, muscle range, muscle movement, muscle weakness, and muscle tonicity is all fairly normal. So that's another way that you can look at to determine the difference between apraxia and dysarthria. With apraxia of speech, primarily it affects articulation and prosody. But that's different than dysarthria because dysarthria it affects all 5 areas of speech. In apraxia, you can also have articulatory groping, which is fairly unique to apraxia by itself. Apraxia can usually occur with damage to the perisylvian area, which is language dominant in that hemisphere. But dysarthria usually is a result of diverse damage. So there's plenty of areas in the brain that you can damage that can result in dysarthria. And then lastly, apraxia of speech co-occurs more frequently with aphasia rather than dysarthria. There's a lot more similarities in aphasia and apraxia, and they can co-occur a lot more frequently than dysarthria. And then patients with apraxia of speech produce automatic speech and emotional speech with very few errors, while those with dysarthria typically demonstrate the same errors regardless of whether overlearned or emotional in nature. So that is a pretty broad overview of the difference between apraxia versus dysarthria and aphasia and how they can co-occur, and how to determine differential diagnosis when you're evaluating them.
Treatment for apraxia is mostly behavior-based. So the goals of these types of treatments would be to focus on phoneme production and motor planning, and also increase the daily independence of the client with apraxia by increasing their ability to communicate in daily life. So, an example of this could be helping specifically with words that they use on a daily basis or could need in an emergency situation. So, some of the aspects of apraxia therapy are success maintenance, repetitive and intensive drills, self-monitoring, and functional words. Along with the daily functions, there are several different lifestyle strategies that could be implemented by a person with apraxia and also with their caregiver. So some of these lifestyle strategies include modifying their everyday environment, informing listeners of their communication needs, and encourage use of strategies learned in therapy in everyday situations. One specific type of treatment for apraxia is articulatory kinematic treatments. So this treatment is based on motor planning and programming principles. So this therapy type is very intensive and very frequent, and it is very important to provide a lot of stimulus cues to the client, such as verbal, auditory, visual, and tactile cueing. A specific example of this is multiple input phoneme therapy, which is for individuals with severe apraxia, and it is for phoneme generalization. And so in a session, the clinician would model a sentence while tapping on the client's arm and the prosodic pattern of the sentence. So throughout this, the targets will increase in complexity and the sentences will get longer. Another type of treatment for apraxia is rate and rhythm procedures. So these focus on intonation, but as well as intonation, they have been shown to improve articulation as well. So as the above therapy type, the complexity of this increases over time. So two examples of this type of treatment are contrastive stress, which highlights a specific word in a sentence, and by stressing that word differently, it changes the meaning of the sentence. And then another type is melodic intonation therapy, which uses melody, rhythm, and stress to induce appropriate speech. But then over time, the reliance on intonation is decreased.
Another treatment approach that can be utilized with apraxia of speech is called alternative and augmentative communication, otherwise referred to as AAC. AAC benefits individuals who cannot, either some of the time or all of the time, rely on their own speech, and it incorporates the individual's full abilities for communicational success and can include speech sounds and vocalizations that the client is already able to do, hand and body gestures, manual signs, and aided communication. AAC is a multidimensional model that is created to allow individual clients to select their own model of communication that would work best for them and for their own speech. It also includes both unaided and aided modes of communication. Unaided communication is typically nonverbal. This includes hand and body gestures, facial expressions, emotions, and motor control involvement. On the other hand, aided communication involves external resources, such as communication boards with pictures or symbols, graphic models, printed words, or computers and tablets. Another treatment approach that is effective to be used with apraxia is called intersystematic facilitation and reorganization treatment. This is where a patient's communication strengths are used to assist their own verbal capacities for speech. Overall, it uses the intact limbic system to facilitate the impaired speech and improve overall intelligibility. It also implements the use of gestures of a client's own limbs to activate speech production. This can include both meaningful gestures and non-meaningful gestures, such as finger and hand tapping. More examples include picture naming tasks, contrast production errors to target productions, use of a mirror for the client to see their own facial positions during speech production. In summary, apraxia of speech is a motor speech disorder that is characterized by inappropriate motor timing and sequencing. It is typically caused by strokes, but can also be caused by degenerative diseases, trauma, and brain tumors. In regards to the effects on speech, it is primarily a disorder that impacts one's articulation and prosody. Speech is overall characterized by slow, labored, halting speech, instances of groping, and fairly consistent speech errors. Apraxia of speech is not caused by muscle weakness, abnormal muscle tone, reduced range of movement, or decreased muscle steadiness. It is a subcategory of ideomotor apraxia, which was a disturbance in performance that is needed to complete an action. And within apraxia, there is a disturbance in the motor speech programmer, which is the neural network used to control sequencing of all speech movements that are necessary. Finally, in regards to the diagnosis of apraxia of speech, it is important to eliminate other conditions that cause speech errors that seem similar to those that are in apraxia. Making differential diagnosis play a significant role within both the evaluation and the treatment process of this speech disorder.